Okay, hello students. So the face-to-face was actually our introduction, and the first video that I posted is actually the maternal child. So this one will be the physiological changes in pregnancy. Okay. So, and again, I'm sorry for any noises. I can't stop the animals on the farm. They're noisy. My rooster gets his crow stuck and the lambs won't stop blatting, but right now they're kind of quiet, so I'm going to go for it. Makes it interesting sometimes. Oops, not what I do. Oh, so physiological. Oh yes, the change is coming. So what happens? The sperm meets the egg. So sperm, there's thousands, trillions of sperm, but only one can get through the egg. And they travel their way actually by smell to get to the egg. And if your man drinks caffeine, just makes the sperm grow, or makes the sperm run faster. Let me put it like that. And that is actually documented, that research, that it happens. So once the sperm gets through the egg, oh dear, I went too far ahead. Only one sperm can get through at a time, and it all changes everything. Okay, what we want to look for in pregnancy are healthy behaviors. My mom is eating 3 meals a day. Or maybe 6 small meals a day. She doesn't have to eat 3 meals. It could be more 6 small meals. She's drinking 6 to 8 glasses of fluids daily. She has is controlling her anxiety. Problems that we can run into is she doesn't have the knowledge. This is her first pregnancy, and she doesn't know anyone that has been pregnant. So these are some of the issues that we might find. Stages of fetal development. So okay, so it's the names. That's something. Okay, you can know those fine. Ovum, from the ovulation to fertilization. So the egg implants itself. Think of this on the upper outer wall. That's where we want it to be implanted. So it's called a zygote from fertilization to implantation, which can take about 7 days totally. And then an embryo from implantation, which is 5 to 8 weeks. 5 to 8 weeks. And the fetus, 5 to 8 weeks until term. And the products of conception or conceptus, okay, are all the structures that are developed. Age of viability is 24 weeks. That's how early the fetus can be born and has a chance of living, of living, if it was born that early at 24 weeks. I just thought this was a little cute, actually. Okay, so the journey of the sperm. Yes, it travels, and oh, the first one there wins the race, right? Once it penetrates the egg, the whole outer enzymes on the egg make it impenetrable to other sperm. Of course, you might have studied this in anatomy and physiology, meiosis and mitosis, how they begin to divide, and as I said, implantation. So think of implantation of that egg is like a seed as it grows. Doesn't it look sort of like a seed? So implants itself, we want it to implant itself on the upper outer wall of the uterus. So a seed, if you think about it, has everything in it that it needs to grow and develop and become another form. It has all the nutrients that it needs to survive. Pregnancy hormones. Oh dear. So this obviously says positive pregnancy. So we look for, sorry, I should go back. How can I go back? All right. So pregnancy hormones, once there's confirmed pregnancy, in other words, we look at HCG, human chorionic gonadotrophin in the urine. That's what turns that pregnancy stick positive. Okay, in the urine. Fetal development. After implantation, then the placenta, the cells divide, and the placenta is formed. Okay, the heart begins to beat about 5 weeks of pregnancy. We have usually a confirmed pregnancy then. And this is just a picture that it shows. So one things that we want to be aware of, and when you go to maternity, you will have the opportunity to go to labor and delivery. And as soon as the baby's born, the structure that you want to look at is the placenta. And you'll see the nurses will be looking at that's the first thing you look at as you're doing your assessment. So we want to look to see, is there one vein? That's the blue vein that runs down the middle there. One vein and two arteries. So not all babies have that. So it's important to look. That's the transport system, as it says, between the mother and the fetus. So the placenta. So it carries all kinds of hormones. uh, Receives the maternal oxygen via diffusion, remember that, and carries the end products for excretion, and also has passive immunity by maternal antibodies, supplies the fetus with carbohydrates, water, inorganic salts, all those things. So the placenta is the lifeline to the fetus, basically. And oftentimes, if there's complications, it's because could be something wrong with the placenta. So another thing, when you're each student will get the opportunity to go to labor and delivery, and as a nurse, we also have to inspect the lobes of the placenta. Okay, so this placenta looks like a healthy placenta. This is the maternal side of it, and we look at the fetal side as well. So if the nurses ask you, here, this is what the placenta looks like, they're showing you because you want to recognize what's normal in a placenta. What's normal is that there's one vein and two arteries, and all the pieces are there, because complications can come from the patient having what's called a retained placenta. In other words, some of the parts are still left in the uterus after delivery. And we want to look at, is it oval in shape, or are there two lobes to it? Does it look like there are pieces that are broken off? So we look at that placenta carefully to see also how it is, the cord itself is implanted into the lobes, how it has grown into the lobes. So if you look at this placenta, and that's a healthy, or sorry, that's a healthy umbilical cord. That's what we're looking at. So the vein runs down the middle, and you can actually see the arteries as they spin around the vein. Okay, that infant was fed very well. It has a healthy placenta, and hopefully has one vein and two arteries. So we look at that. So what does the one vein do? It carries oxygen and nutrients from the mother to the baby. And the two arteries gets rid of all the waste, and to be processed and disposed of by the mother, her kidneys. So if she has kidney problems, then there could be a complication here. Amniotic fluid. Sorry, I got to shut the door. Amniotic fluid. So The amniotic fluid is the bag of water that the fetus grows in. What happens, or what is the amniotic fluid for? Well, number one, it protects the infant. It protects the infant if mom falls, or she falls down the stairs, or she's in a car accident. It's like that bubble that protects the baby inside of her. The amniotic fluid also protects the fetus from bacteria and germs that should get inside of the uterus. So, and it also is its temperature control. It's a great and great room to live in. It's nice and warm, and keeps helps the fetus. So it cushions the fetus. And one thing I didn't say, it facilitates fetal growth and development. In other words, so the amniotic fluid, you can think of it as a body of water that the fetus grows in, and it helps for buoyancy. It helps as the infant, if you think about jumping into the pool or into the water, and your legs and arms are spread out, it helps those arms and legs to grow symmetrically because they're floating. Okay, so it helps with that. Provides oral fluid. It gradually increases and surrounds the embryo. It doesn't grow stagnant, it's constantly moving. So the fetus swallows this, okay? And it's formed from the amnion. You can see my little man there where it says that's important. So pregnancy. Pregnancies can, so this is should be, it is in your book, planned and unplanned. So signs of pregnancy. We're presuming she's pregnant. Her periods have stopped. Her breasts are a little bit tender, and obviously a health provider would recognize that there's like a vaginal mucosa discoloration. It's like a bluish color. It's called Chadwick's sign. And their skin changes, and the baby or the abdomen is starting to enlarge. Obviously, the symptoms, however, nausea, vomiting, fatigue, quickening, breast tenderness, all of these are symptoms. As the infant grows, it presses upon the bladder, which creates urinary frequency. Obviously, we see weight gain and constipation. So those are called presumptive. This is probably she's pregnant, we're going to say. There's uterine changes when you check her. There's a softening, cervical softening, blottment. Blottment is like if there was a ball in the water and you pushed it down under the water, it would bounce back up to you. That's the same as laying your hands on the mom's abdomen. If you push down it, you could feel it bounce back up at you, the fetus, right? HCG, human chorionic gonadotropin, those laboratory tests, they can be tested in urine at home. Confirmation, you might want to go to the hospital and they'll test a blood test, which is HCG as well. So we're presuming we took an at home urine test and it showed positive. All of these things are probable. But the positive evidence, yes, there is a fetus in there, is we have a heartbeat when we take listen to it by a Doppler. There's a fetal outline. We can confirm. Usually, the physician, if there's a question of whether or not there's a pregnancy, the first thing the physician will do is send the mom for ultrasound for verification. We'll tell her to drink lots of water before she goes for that ultrasound, because if she doesn't, we won't get a good visual on what's on anything inside of the uterus. Of course, fetal movement. So I can tell you the story of a young lady that came from New York City in the fall to visit family up here. I can still recall it. And she presented in the ER with abdominal pain and cramping. And she had never told anyone that she was pregnant, none of her family members. She was thin, she wore big sweatshirts, and obviously the abdominal cramping was she was in labor. And that night she delivered a baby, which was a surprise for everyone. But when the provider went to in the in the emergency room went to check her, you could feel the outline of the infant. You could feel the fetal back, and of course, you got a fetal heartbeat. And I guess the story was when he laid his hand on her belly, the baby kicked him. So I thought that was a good story to tell. True story, by the way. So the whole body goes through significant changes. Amenorrhea, which is absence of the menstrual cycle, or yes, the menstrual period, I should say. So the uterus goes through the most significant changes. It changes to from 50 to 1,000 grams. Wow, that's quite a bit. And the shape changes, soft globe that enlarges, rises out of the pelvis by the end of the first trimester. So that what that means, at the end of the first trimester, you can usually palpate the top of the uterus as it rises out of the pelvis. And it continues to grow. That's what we wanted to see for a healthy pregnancy. So and I already said implantation occurs at the outermost surface, upper outer wall, I call it. Okay. So things that you would see is the cervix softening of the cervix. Oops, I'm trying to get a better picture here. What happened? It's called Goodell's sign. Okay, so the cervical glands and the mucus plug, there's a plug in there that keeps, sorry, just trying to get a better picture. What happened? That keeps bacteria and germs from getting into the uterus. There's a plug that forms. However, yes, is to stop bacteria and germs from getting in there. I'll stop that. All right. I'm gonna have to pause. There, I think I have it now. All right. So, so that plug that's formed stops the bacteria and germs from coming up into the uterus. When the patient, a couple of weeks prior to delivering, she'll lose that plug. That's why I call it popping your cork. Sorry, couldn't help that. All right. So there's that bluish violet hue. You can tell, you can visually see that as a practitioner. It's called Chadwick's sign. Not that I really want you to remember all that, the name of it, but know that there's a change. Okay, so in ovulation, she stops ovulating, okay? So the FSH and the luteinizing hormone, high levels of estrogen and progesterone. What that progesterone does, it helps to build up the bed of the endometrium so that that egg has a nice soft bed to lie in. Corpus luteum remains active. That's what it's called. The egg that I've been talking about, it's called the corpus luteum, and it stays in there and it grows till about 8 to 10 weeks. The placenta is formed, and the heart begins to beat. About 8 to 10 weeks, the placenta takes over. Okay, it produces progesterone and estrogen to maintain the pregnancy after that around 10 weeks, let's say, like that, to be precise. So oftentimes if the progesterone levels are low, that's usually when a woman miscarries, because she doesn't have enough of those hormones to maintain the pregnancy. So 8 to 10 weeks is normal. That's when the placenta takes over, and if it can't, then she miscarries. If that makes sense. So one of the first things you'll see is a heartbeat. If you took anatomy and physiology, you remember that the cardiac muscle can beat all on its own. First, one part of it starts to beat, and then they all synchronize. And so it's about 5 to 6 weeks. You can see that on ultrasound, and that is called positive pregnancy. It's a positive pregnancy time sign. There's no doubting. So some of the breast changes, obviously the breasts enlarge, and the areola and the nipple, which is at the end of the breast, they darken. And there you can see the veins. This is all preparing God's great purposes for us to feed our babies through the breast. Okay, colostrum is secreted in the colostrum. I call that the liquid gold. We'll talk about that later. But just know that estrogen progesterone levels create hypertrophy of the mammary glands or the breasts, and often they're very sensitive to touch as well. And you can feel that cardiovascular slight enlargement 12%, but the blood volume is what's important. That's what our how our body prepares for at or during delivery is increases by 40 to 50% or even more if there's more than one baby. It's not uncommon to have murmurs during pregnancy because of that increased blood volume. Now you can read this same as I can, so I'm going to let you read it. But let's see, there was a young lady actually. She was a school teacher in my son's school, and she actually died after delivery. I think it was, I don't know, maybe a month after delivery. She actually died of a undiagnosed heart condition that and all of her body could not handle the increased blood volume and blood loss afterwards. She yes, she ended up dying, and that was like maybe this summer that it's happened. So it's important when you're doing your health assessments on your patient that you cover all areas just like you did in 111. It's no different. You check out your patient's heartbeat. And is called oh my gosh, what's it called? Well, it's called a murmur, but they it's not it's common to have murmurs, and they usually go away after delivery. Benign murmurs, that's what I was looking for. So as the pregnancy advances, the heart actually can be displaced during pregnancy. Things because of that increased blood volume, you also can have varicose veins in the legs, but not only in the legs, but I've seen them in the vaginal area as well. So blood changes, so you have to look at those. The most important ones that we look at are hemoglobin and hematocrit. So where did this patient start from when she was first diagnosed as being pregnant? What was her H&H? So she may need some iron if it's really low, or she may have anemia. Um, she may need it once a day, twice a day, 3 times a day. It depends. And maybe she was prescribed the iron. However, she didn't take it because it make her stomach upset. So her H&H may continue to be low. So she comes in for delivery and she has a low H&H is what you want to look at when she comes in. It's going to be even lower after she delivers. So it's important to know where did she start with in her basic assessment, what was her H&H at? And of course her respiratory rate and whatnot. Um, So these are some skin changes that you may see. So this one here is called linear negre. It's basically a darkened line that goes from the suprapubic region to the navel of the mom. And it's just a hormone of pregnancy, a sign of pregnancy. This over here is called the mask of pregnancy. You can see the discolorations around the face. So, and that's typical because of hormones. And I had already mentioned the breast changes, the darkened areola and enlarged breasts. Another thing that I actually recognized was a person that came to me and couldn't understand why her palms of her hands were red and itchy, and that also actually is a sign of pregnancy. It is a hormone change. So, like I said, know what's normal and recognize abnormal. These are expected normal changes that during pregnancy. So, increase in blood and plasma volume, we kind of already talked about that. To maintain normal blood pressure, basically, that's what it's all for. Okay. You'll see an increase in gases. You can read all this same as I can. And it's a buildup of volume so that the body can prepare for the time of delivery. And some of the normal things you would see was increased edema in the lower extremities, such as the ankles, later in the pregnancy. So, in the GI system, well, nausea and vomiting, that's due to hormones, yes. Evidence-based practice. So, what this means is back we used to tell patients not to go to the dentist, but evidence-based practice tells us if mom has poor dentition, she's more likely to also have preterm labor. So we want her now to go to the dentist, and within that first visit we'll recommend to the mom to make a dental appointment. Okay, we don't want any preterm problems, and also we don't want her to transmit that to her unborn child, any dental complications or problems. Okay. Renal structure changes, which urinary stasis increases. So anytime the woman has, let's say she's always had a problem with UTIs, so they're just going to get worse with pregnancy. Anytime she has any complication, could be asthma, could be any other health related issues, it either gets better or get worse. But with urinary, some of the things that we want to keep track of, we already know she has UTI issues. Is she wiping front to back? Is she drinking enough fluids? And so we want to make sure that we follow up on those with our patients. She may need antibiotics. We already said about this positive time by Doppler. As the pregnancy progresses, this may be you get the waddle from the relaxed mobility of the joints. You get that waddle and whatnot. Diastasis recti is where the abdominal muscles. Now you see some women, they've had several children and look like they're still pregnant. That's because those abdominal muscles can actually separate and during pregnancy, and they never, because they're muscles, they tear and they don't really go back, and the only way to correct them is through surgery. And so it's called diastasis recti, that you'll see those muscles separate. That happened with my third pregnancy. I tell her she ruined me. Okay, so we talked about the placenta. And the placenta here, it shows it's attached to the upper outer wall of the uterus, okay? And the umbilical cord is what? One vein, and you've got two arteries that wrap around it. So we want to one of the things that they look at is that blood perfusion, and is there actually one vein and two arteries, and where is the placenta implanted at? The provider may send the patient for an ultrasound to determine that. So the pituitary gland, obviously, if the patient is pregnant, the FSH and LH are suppressed. These are some of the things that you may see. And you know that the posterior lobe is where the oxytocin is produced. And that might be the kicker that says get out, because oxytocin is increased. But just know that all of the functions of the body are impacted by pregnancy. The thyroid metabolic increases your metabolic rate. So yes, patients that have thyroid condition, we want to make sure she is stable before she even gets pregnant. Okay, you can read all of these here. So there may be complications with insulin, diabetes, think of that. Okay, so here we go. More prone to infection. The patient being pregnant is more prone to infection. Her immune system is compromised, yes. So we want to make sure she washes her hands, she wipes front to back, she eats healthy foods, and she drinks 6 to 8 glasses of water a day. So and this talks about the Ig are decreased because of cross-placental transfer to the fetus. So yes, she is compromised. Oh, palpate. When you feel the baby kick, when the provider lays or mom lays her hand on her belly, she can usually feel the baby around, fetus, I should say, around 14 weeks. Okay. And it grows pretty rapidly from there. So we talk about HCG hormones. One of the things that the providers can look at is take HCG levels. We want to know that the HCG levels are increasing. Okay. If there's a question of a miscarriage, the patient may have to come back in more frequently to look at those HCG levels. Maybe they're going down because the patient is miscarrying. So it talks about the different levels here. So as I said before, there's presumptive, improbable, okay, signs of pregnancy, and there's also the positive. The only 3 positive signs. So everything else is either presumptive or probable, but 3 positive signs. Can actually feel the fetus, because at 20 weeks the level of the top of the uterus, which is what the house the baby lives in, is at the mom's navel. That's where it's located. So usually urine tests it does measure HCG, human chorionic gonadotropin. Those are those at home tests, or even you can get those at the hospital too. But a more definitive level would be a blood test that would tell you more precise how many weeks along the patient is and such. The urine test only tells you whether it's positive or negative. So this is something that you will be asked on an exam or even on the NCLEX, how to calculate the date of delivery, and it's called Nagel's rule. So this is how you do it here. And you ask the patient the first day of the last menstrual period. So you add a year minus 3 months plus 7 days. Then you get the calculated date of delivery. Now, let's say she doesn't know, then the provider's probably going to send her for ultrasound to determine an estimated due date. So you might see this as an EDC, estimated um, or EDD, estimated due date, or estimated date of confinement. They call it EDC. You can see it either way. Either way, what they're talking about is Nagel's rule. And you can also have McDonald's rule. This isn't the burger either. Anyway, what McDonald's rule is: if you take a regular measuring tape, it also measures in centimeters. In measuring from the top of the suprapubic bone to the top of the fundus, you have to palpate and feel for that. correlates to the centimeter measurement of how many weeks the fetus is. Like, is it 20 weeks, 21 weeks, 22 weeks? So remember, a measurement, it can be plus or minus 2 weeks after 24 weeks. What that means is, unless she had an in vitro fertilization and knew exactly when she got pregnant, or she was counting her, oh, I don't know what levels they are. Well, I do, but um, then we always count it plus or minus 2 weeks, because she can deliver 2 weeks before the due date or 2 weeks after the due date. So let's say we measured her this week. She came in for her weekly or her monthly prenatal visit. We measured her abdomen and it was 20 weeks. And the next month she comes in and she's 21 weeks. So she would be right on target if that's where she's supposed to be. But let's say she came in the next month and she still measured 20 weeks. That means there may be a problem with this fetus as it's not growing. And compared to how many, how far along she is in the pregnancy, let's say she's supposed to be 24 weeks, but she's only measuring 20 weeks. That could be called small for gestational age, or SGA. Or she's supposed to be 24 weeks, but she's measuring 30. So that could be LGA, large for gestational age. So it's important that we keep track of how the infant or the fetuses progress from month to month or week to week. And that's what we do on a prenatal visit. So the provider could send the patient for a sonogram or an ultrasound to get a visual on, is there a heartbeat, what's going on with this infant, how is it measuring. They can measure femur length. They can look at many different aspects of the fetus through an ultrasound, or a sonogram it's called. And the important thing is we want to make sure mom has a full bladder when we do it, so we can get a better visual picture of it. So these are some of the nursing diagnoses you could potentially use in this early pregnancy: knowledge deficit, um, and alterations in comfort, alterations in bowel if she's not drinking enough fluids or getting enough exercise, and of course fatigue. So those are some potential ones. So if I look at this fetus, some of the things that I can identify, knowing this is I would say an early fetus, it could be, let's say, preterm, because one of the things that you see in fetuses, they are protected with this vernix, which is a cheesy-like substance all over the infant's body, covered head to toe. And as the fetus matures, that vernix sloughs away. So by term, it doesn't have any vernix. So let's say the providers decided to induce the patient. He says she's post-term, but yet when this fetus is born is covered with vernix, it could be somebody's dates were off, okay? And even that downy hair, that my kids look like little monkeys when they were born. They had this little downy hair all over them. That does slop up too. But that can give you a clue as to dates with maybe this fetus was actually premature versus due. Okay, how you like that? So, all right, shh, shh, shh.